Oman Family Medicine Society in collaboration with Dakhlya Healthcare Committee. As usual, our CME is launched on the Zoom, and it will be recorded on the YouTube. You can see it, inshallah, after a few days. This CME is almost accredited, and you need to attend at least 30 minutes to get your CME credit hour. Of course, we have the chat area where you can put your comments on the audio, visual, or the sound, etc. And we have the question and answer. We like to ask you to put your questions on that area so we can respond to it by the end of the session. And you can, by the end, either you can ask your question through Q&As, or you can ask it through the raise hand to speak verbally. Today's speaker with us is Dr. Haitham Al-Mahrouqi. He's an ophthalmologist at Al-Nahdha hospital. He's keen and he's doing a lot of CMEs for residents and general practitioners on the common eye conditions. And he has some publications already. He's active, and we hope to get more cited in text PubMed researches, inshallah. And we hope this session will last for about 45 minutes, with the question reach 1 hour. So, let's start. Dr. Haitham, the floor is yours.
Assalamu alaikum wa rahmatullah. Shukran, Dr. Zahir. It's a pleasure being here among you all. I've had the pleasure of meeting many of you actually during your FAMCO rotations, maybe at Al-Nahdha hospital, or we met somewhere or another. Anyway, it's a privilege, honestly, giving this talk. This is an approach to common eye conditions in primary health care. I will try to, in this talk, cover very important topics, and these are basically ocular trauma, acute red eye, and acute visual loss. These are the three main conditions or presentations that you need to know something about and know how to manage and when to refer. The others, there are some others like chronic eye conditions that others will deal with, and you'll need only to refer them to the polyclinics. Sorry, this is a webinar, so it won't be very interactive, but I hope to have some questions at the end so we can have some interaction. This is statistics from Al-Nahdha hospital where I work. We see about 50,000 cases in our A&E. About 10,000 are actually ophthalmology cases, so about 20%. And about 10% of those are ocular trauma cases. And I'm 100% sure that you're seeing a lot of ocular trauma in your general practice. And the ophthalmology conditions, there are about 5% of all GP visits. But these are statistics from the UK, and I hope to have some idea of how many of your visits are actually ophthalmology related. I'll start by going general about on ophthalmic history and examination, very important things in examination. Then we'll go through some of the very important conditions. The ophthalmology ophthalmic history is not special at all, honestly. It's important in trauma to know the exact mechanism. And I'll speak a little bit more about that, whether the trauma is blunt or sharp, whether it's like a ball, it's a blunt end, or a sharp like a needle or something like this, because this will tell you whether the ocular trauma is an open globe injury or a closed globe injury. And it's important to know how the size of it, because the orbit here around the eye covers or protects the eye. And so it's important to know how big the object is and whether it's high-speed flying object or not. In terms of acute red eye, it's important to know whether there is reduction in vision. Reduction in vision is very important because the most common condition probably that you see is conjunctivitis, and conjunctivitis has nothing to do with decreased vision. It's not in the visual axis. The visual axis starts from the cornea and going backwards. The conjunctivitis does not at all deal with or associate with reduction in vision. In terms of acute visual loss, the exact description is very important, because some patients may have what we call metamorphopsia. It means that things are wiggly. When you see it, when you see, let's say, a straight pole, you see it sort of in a zigzag fashion. You need to know whether the acute visual loss is peripheral, and you know from your practice that retinal detachments and others, they present with a visual field defect, and the visual field defect might be actually peripheral and not central. And so these are very important in terms of acute visual loss. And I hope that many of you have heard about the vital signs of the eye. Some of you might laugh at this, but this is very important. There are vital signs of the eye when a patient presents to you. And I can assure you that if a patient presents to you with acute chest pain, you will not know the diagnosis of that acute chest pain if you don't have the temperature, the blood pressure, and the heart rate. And it's very similar in the ophthalmic examination. There are vital signs that you need to document, and you need to document for your diagnosis and when to refer these patients. So we'll start. This is the first case. This is a 28-year-old man with 5-day history of right eye redness and watery discharge. And you can see that the whole eye is red. Dr. Zahir, can you see my cursor? Is it in the screen? It's
yeah, it is there in the screen. It's visible.
Okay, so you can see that this is an eye redness, but you can see the cornea is crystal clear. And so the first vital sign is the visual acuity. The visual Snellen chart is available in all healthcare centers. And so you use it to know the visual acuity of patients. And also, whenever they come with an eye condition, document the visual acuity, because in their subsequent visits, you'll know whether the visual acuity has dropped or not. And I hope that you guys are doing this. There's another case, a 25-year-old lady, and these are, by the way, very common cases that we see with a 5-day history of left eye gradual reduction in vision. And there is pain with eye movement, and the visual acuity, sorry about the shortcuts. VA means visual acuity. OD means ocular dexterous, it's the right eye, 6.6, and the left eye, which is OS, is 660. And if you see the eye, it's beautiful, it's pristine, it's white. There's nothing that will give you the diagnosis unless we do the pupillary reaction. And then in this lady, you'll see a relative afferent pupillary defect. I just want to show you a small clip on how to examine relative afferent pupillary defect.
Hi, today we're looking at relative afferent pupil defect.
Can you hear the sound, Dr. Zahir? Okay,
RAPD. This is also sometimes referred to as Marcus gun pupil. First, we will compare its clinical appearance with that of normal pupils and also that of a complete afferent pupil defect. To avoid pupil constriction whilst accommodating, ask the patient to fix on a distant object throughout your examination. Look for equal pupil sizes and check again with the lights off. Anisocoria is not a feature of an afferent defect. Now check for a reaction to light in each eye, again with the lights off. Here, the normal pupils constrict briskly, then relax a little. They dilate again after the light is removed.
So this is what he tested is the direct and consensual response. So if a light is shown into one eye, the other eye will constrict, and when you shine to the other eye, the same thing will happen. Now he'll do the alternate shining.
Now swing the light from eye to eye quickly, but pausing on each eye for around 2 seconds. In the normal patient, the pupils will constrict, then relax a little each time the light is swung to them. Now a patient with a relative afferent defect. The pupils will be equal in size in both light and dark. Both pupils will react to light, although sometimes a slower response is noted when light is shone on the affected side. With the swinging light test, the RAPD now becomes obvious. On the affected side, both pupils dilate when the light is swung across. Here,
so you see that there is in the left eye a relative afferent pupillary defect. When the light is swung to the left eye, the pupils dilate rather than constrict. And this is a relative afferent pupillary defect, means that the optic nerve in the left eye is not functioning well.
Side is affected. You will miss an RAPD if you do not do the swing light test, as it is only by comparing the relative strengths of the signals reaching them.
So this is very important, and this video is available actually on YouTube. So have a look at it, because this is very important in terms of diagnosing optic nerve conditions. This
Dr.
is
Haitham,
the
if you'd like to ask question, people, they can reply on the chat, I mean, like in your cases, if you are...
Okay. That's fine. So we can open the chat. It's okay. We can have it at the end. So this is a 50-year-old lady with abrupt onset of right eye pain. The visual acuity is 360, so it's very reduced, and the pupil is mid-dilated fixed. I'm sure that you have seen this condition many times, and you have learned about it many times. This is when you see that there is redness, and this type of redness is very characteristic of what we call ciliary congestion. The redness is just around the cornea here, but if you superiorly in the conjunctiva, it's actually white, and if you let the patient look superiorly also down, it'll be white. But the redness is confined to just around the cornea. It's called limbal or circumcorneal or ciliary congestion. The cornea here is also not very clear, and the pupil is mid-dilated fixed. And so the third vital sign is intraocular pressure. You might ask me how to measure the intraocular pressure in public, in the GB setting. You can do it digitally. This is very easily done, because in acute angle closure, it's actually one eye which is affected. So if you let the patient, like in this picture, you let the patient look down and you just feel with your fingers, both fingers, you just feel your globe. So you look down and you just feel the globe. It feels like this. So it feels just like a muscle or just like a thick skin kind of feeling. But and there is if it's an acute angle closure, it'll feel like a knuckle. It'll feel very stony hard, and you can always feel the other eye. The other one is a tonopen, and I hope from this talk, because we have a lot of GB people here or FAMCO doctors, that we can institute tonopens in some, at least the polyclinics around. This is very important. This is a very simple device. It doesn't cost a lot of money, and it's important to measure the intraocular pressure. But digitally, you can do it. And I'm sure many of you have seen it in some of the emergency departments. So in conclusion, the vital signs are visual acuity, pupillary reaction, intraocular pressure. Please do not refer any patients unless you document these, because these are very important for you to reach a diagnosis and for us to know and to categorize when to see such patients. And these vital signs will cover you medico-legally. So we start with some conditions. This is an ocular trauma. This is very important because you probably see a lot of ocular trauma in your practice. This is a picture showing that there is an open globe and the iris is actually coming out from that wound, and it's incarcerated in the full thickness corneal wound, and that's why you see the pupil is peaked. But do not forget that ocular trauma might be associated with other trauma, and we do see a lot of patients refer to us who come to the emergency department, and they have multi-trauma or in a setting of a car crash or something like this. So it's very important that you save life first, ABC, and then you save the function or the organ, and then you save the function of that organ. We do classify injuries in terms of open globe and closed globe. Open globe is very important, like in the picture that I showed you, because you need to suture the globe, and you need to institute or restore a fluid and you need to restore the integrity of the globe, that it is a ball which is watertight. But in closed globe injuries might be also actually very severe, and we'll look at it. But we normally classify it into open globe and closed globe. The mechanism is very important, as I told you before, in ocular trauma. Sharp versus blunt is the main thing, as well as the low speed and the high speed. The sharp will give you open globe. The blunt will not give you open globe, but it will give you the sort of blunt trauma that we will see now. Imagine that there is a high-speed flying object, like in a cricket ball, that it has hit the eye. The eye compresses from anterior to posterior, so it compresses in this axial view. So it decreases in axial length, but on the same setting, the equatorial or superior to inferior, it will increase in the diameter, and so and then it will come back and it will oscillate, and the eye inside, all the structures inside the eye are actually circular. The iris is circular, the lens is circular, the retina is circular, the optic nerve is circular. And these things, when the circles compress and then dilate, many things can happen inside. There are various traumas to the globe, and I'm probably sure that many of you have seen. This is a foreign body. This is a patient that after working, he was a mechanic and cutting steel. There's a small piece of steel that has been stuck in the cornea, and you can see it actually even with the naked eye. But before removing this, you need to know whether this is actually deep or not deep. If you can assess this in the emergency department, if you're working in the emergency department, yes. But in general practice, I'd rather that you refer such a case and we remove it, because you don't know how deep this has went. There's another case. This is, as I showed you in the previous photo, this is an iris incarcerated in a wound. This is hyphema. These hyphemas happen after closed globe injuries with a high-speed flying object. This is blood in the anterior chamber, and it takes time for the blood to resolve, but these patients are prone to have high intraocular pressure. This is another picture. It's showing subconjunctival hemorrhage. If it's a spontaneous subconjunctival hemorrhage, I'm not bothered. Actually, you can just manage it in the primary healthcare facility, and you look at whether the patient is hypertensive or taking any blood thinners. But if this is a sharp trauma, look, this is an area here where the blood is more thick. There might be actually laceration in the sclera just posterior to this. So be careful and take very good history from the patient on the mechanism of trauma. This is an open globe injury. Also, this is the third time that I show you. The iris might not come out, but what you can do in open globe injuries, you need to refer these patients straight away. What you can do in the primary healthcare setting is you put a shield, and I'm not sure. I'll write actually these things to discuss this among you. If you have a shield at the healthcare facility, you can put a shield, tetanus toxoid. So check with the patient if the patient has been vaccinated, has taken the tetanus vaccine or not. And if not, you should give the tetanus toxoid and give a shot of IV antibiotics. Ceftriaxone is very good. And just refer the patient. We'll do CT scan just to exclude an intraocular foreign body. And this needs primary repair, means that we need to suture the wound within 24 hours. Otherwise, they will have a florid infection inside the eye that's called endophthalmitis, where we cannot actually save the globe. This is a very nice, and this is another one, the fluorescein strip. And I'm sure that I've asked before that you guys do have fluorescein in the primary healthcare. This is a patient, if you don't know whether it's open globe or not, just put fluorescein and you'll see aqueous coming out and diluting the fluorescein. So this is aqueous coming from this wound. It's called Seidle's test. Another very important topic is chemical injury. This is a genuine emergency. Every second counts. So when a patient presents with chemical injury, please do not refer the patient straight away. Please irrigate, and you should irrigate. You should irrigate with at least 1 liter, and you can put a cannula on an IV bag, let's say 1 liter with a cannula, and you just put a local anesthetic for the patient, because they'll feel much better. And you just irrigate, go and irrigate, let the patient see up and down, irrigate, and then refer the patient. So I'm writing these things for the questions at the end. And you should irrigate for at least 30 minutes or with at least 1 bag of saline. This is a patient that was not irrigated straight away. The chemical injury can be devastating to the globe. It will lead to corneal melting and corneal opacification, as well as the lids will be distorted because there'll be fibrosis, and there'll be a reduction in the fornices and things like this. And these patients, even in the future, even a corneal transplant might not be effective. This is a welding arc. You'll actually maybe see patients coming to you, but they do come to our emergency department very often. A patient after welding without wearing protective glasses, and when they come to you, they come with foreign body sensation and photophobia. They cannot open the eyes. And when you look at the eye, you'll see that this is ciliary congestion. You see the redness just around the cornea. And if you see the cornea, it's actually pristine. It's beautiful. There's nothing wrong with the cornea. But if you put fluorescein, you see these punctate erosions all over the cornea. So fluorescein is very important. You know that the welding, the ultraviolet is toxic to the corneal epithelium, and it dies. And this needs about 2 to 3 days for the epithelium to regenerate. And what you can do for these patients, you can give them just a very frequent ointment, whatever ointment that you have. Maybe I think you do have tetracycline ointment and chloramphenicol eye drops, as well as very frequent lubrication, just artificial tears, and see the patients in 2 to 3 days time, they'll be fine. Childhood injuries are very important in children, and if you cannot diagnose them, please refer straight away, because these patients are also prone. This is a study that we have done in Al-Nahdha hospital, and we saw that the open globe injury is also in 10% in children, and the cornea is the most effective tissue. Okay, we'll change gears a little bit. We'll go to acute red eye. This is also very important to you. This is the picture that I want you to really know very well. Look at the first picture here, first picture on the left side. This is, it's called generalized congestion. Generalized congestion means that the whole conjunctiva is congested. But if you look at this, this is just next to the limbus in the cornea. You see it's white actually. It's in contrast to this picture in the right, where you see the redness is just around the cornea, and you see the vessels are radially coming from around that limbus. This is called ciliary congestion. This is called generalized conjunctival congestion. The ciliary congestion is a true urgent case because there are 3 conditions that cause ciliary congestion, and I will tell you about them in a moment. Okay. Another difference that I want you to know is the difference between a corneal ulcer, a keratitis, and an abrasion. The difference is an abrasion is an epithelial defect. If you remember the structure of the cornea, the first part of the cornea is just epithelium, and it heals very quickly. But a keratitis is an epithelial defect, basically an abrasion, but there is infiltration, which is an inflammatory reaction in the cornea. This is a patient with an abrasion. If you look at the cornea without fluorescein, you will not see anything. But if you put fluorescein, you'll see that the fluorescein is uptaken by the cornea. But this is another case. This is a case with keratitis, basically a corneal ulcer. There is an epithelial defect, but you see this white opacification. This is an inflammatory infiltration, basically white blood cells that they're going to kill the bacteria, which is inside the cornea. And this is a hypopyon, basically pus inside the anterior chamber. And if you put fluorescein for these patients, yes, fluorescein, there'd be an uptake because there is an epithelial defect. And that's why the bacteria went into that cornea. So this is very important, the distinction between an abrasion and a corneal ulcer. A corneal ulcer, we need to see it on an urgent basis. But an abrasion, you're more than welcome to only actually treat it in primary practice with chloramphenicol, just an antibiotic, a prophylaxis, and maybe an ointment at night and artificial tears. And they will heal in 2 days' time. You just need to see them in a couple of days' time. So the causes of ciliary congestion is any acute corneal disease, so an abrasion or an ulcer. And these are also acute conditions. A uveitis or an acute angle closure. Honestly, if you pick the phone to refer any case to me and you saw that this patient does have ciliary congestion and it's not only an abrasion, I will accept the case straight away because it's an urgent case. We'll speak later on about urgent cases and emergent cases. There are only few cases in ophthalmology which are really true emergencies, and we need to see them straight away, and I'll show them to you a bit later on. So in terms of differential diagnosis for acute red eye, you start from anterior to posterior, so conjunctivitis, episcleritis, scleritis, in the cornea, keratitis, posterior to that, uveitis, and a high IOP is acute angle closure glaucoma. We look at it one by one. This is a conjunctivitis, very important. Conjunctivitis does not affect vision. So if you measure visual acuity, the visual acuity will be normal unless the patient has a lot of pus. And this is the hallmark of bacterial conjunctivitis, is actually pus. And the pus, if you clean the pus, now after 5 minutes, there'll be more pus. Patients that do not have pus are unlikely to have bacterial conjunctivitis unless they're very, very little children, like newborns, or very, very old patients that do not embark on a very high inflammatory response. But pus is the hallmark. And you have to measure visual acuity for these patients, and chloramphenicol, the one that you have, is more than sufficient for these cases, and they will improve. But there is, and so in conjunctivitis, there are, the most common is viral conjunctivitis, and these patients do not need anything but artificial tears. But if the patient has reduction in vision, please refer these patients because the cornea can get affected in minority of cases. In bacteria, you need to give antibacterial. In allergic reactions, and allergic conjunctivitis patients might have history of atopy and history of recurrent eye redness. And the redness is not florid, it's not huge, the redness, and they'll be associated with eye itching. And you can give in these settings antihistamine. Forget about the mast cell stabilizers. There are sort of medications that are reserved for ophthalmologists, but you can give them antihistamines. And this is another one, if we can, antihistamines, they're available in the healthcare facility, in the primary healthcare. There is one type of conjunctivitis that I don't want you to miss, and I don't want you to be very relaxed about. And these are conjunctivitis in the newborn. It's called ophthalmia neonatorum, and this needs systemic antibiotics and topical antibiotics because the organism is frequently very virulent organisms like gonorrhea and chlamydia, and these patients need systemic antibiotics because these organisms can also give other manifestations like pneumonia and other things, and you need to kill them promptly because the cornea can get affected and they can get keratitis. We'll move to Episcleritis, Scleritis. These patients have sectoral redness, like in this picture. So the rest of the conjunctivitis is actually not red, but it's sectoral. As in this picture also, this is scleritis, and the redness is sectoral. So if you look at here temporally in this side, in this left or right picture to the right-hand side, you'll see that actually the conjunctiva is white. So any sectoral redness, think about episcleritis, scleritis, or even an inflamed pterygium. These patients need to be referred the next morning. We don't need to see them on an urgent basis. Unless it's an inflamed pterygium, just give artificial tears for these patients. This is keratitis, similar to the picture that I showed you before. These are fungal and bacterial keratitis. There are other ones like viral HSV keratitis. These are dendrites, and maybe you've seen them when you rotated in your ophthalmology rotations. But you can see them actually only with fluorescein. And these patients need to be seen the next morning because we give them acyclovir, either topical or systemic. Other conditions that I need you to take seriously are contact lens wearers, induced keratitis. If a patient comes to you with contact lenses and a red eye, please take it seriously. And these colored contact lenses, we've seen very sad stories with patients with contact lenses. And these patients, a lot of these patients are actually young girls who even exchange colored contact lenses. They do not take really good care about cleaning them. And also they buy them off the internet and from shops that are really not good contact lenses. And they end up having severe infections, keratitis, and many of them actually need corneal transplantation. Many of these patients have Pseudomonas keratitis, and these patients can perforate within 24 hours. I actually, if a patient comes to me, and we do see patients coming from weddings in the middle of the night with eye redness after wearing colored contact lenses, and if they come to us in the emergency department, we never say no, we see them. This is another condition, uveitis. You probably have seen uveitis before. You look at this. Look at this ciliary congestion. It's florid ciliary congestion. And if you stain the cornea, there'll be nothing. But you know that the ciliary congestion might point out towards high IOP or a uveitis, and then you'll send the patients. In these patients, you will have myosis. So we'll have small pupil, or if it's in a chronic uveitis, the iris might get stuck to the posterior lens, and these are called posterior synechia. And these irises or the pupil will be distorted. And you can send the patients the next morning. This is the condition, acute angle closure. This is a true emergency. So I need to see these patients immediately. So you send these patients immediately because the IOP is so high that the optic nerve can get affected in few hours. And these patients need basically admission and lowering of the intraocular pressure, and they need further management from our side. I hope I can ask these questions, but I'll ask these questions maybe towards the end. And I hope that you guys know the answer to this question. This is a patient, you see, this is a corneal transplantation. And a patient like this comes in with foreign body sensation. And if you look at the cornea, see the ciliary congestion? The rest of the conjunctiva is actually white. But if you look at this is ciliary congestion. You know that there is a problem in the cornea. And if you put fluorescein, you might not see anything because this is rejection. This is internal. It's called endothelial rejection. And you can see these white lines because this is rejection in the cornea. So please, a corneal transplant, please take it seriously. If a patient comes to you with a corneal transplant, please send the patient straight away to the emergency department to be seen by an ophthalmologist. Okay, so this is finished from the red eye. This is the last topic, acute visual loss, and then we'll open to some discussion. I hope we do have a really good discussion. Acute visual loss, we do or visual loss in general, we classify it in acute or gradual. Gradual visual loss, honestly, if you do nothing about them, you just refer them to the ophthalmologist. The ophthalmologist will do everything to reverse that. So if a patient comes in with a reduction, so we look at gradual first to get it out of the way. If a patient comes in with glare, means that when they look at light, they look at light going, like when you're driving and the windshield is not clean, you'll see the light going everywhere. This is called glare, and this is typical of cataract. And a patient comes in with gradual reduction in vision, their old age, they will probably have cataract. And you look at the eye. If the cataract is advanced, you might see a white behind the pupil. If a patient is diabetic, think about retinopathy. If a patient is very, very old, or in some in around the world, like the Caucasians, they have age-related macular degeneration, but this is a condition that we don't see very often in Oman. If they have a family history of glaucoma, think about glaucoma. Okay, so this is gradual reduction in vision. You probably know all about it. You just refer the patient to the polyclinic. But you need to document all the vital signs of the patient and just a general examination of the patient. If a patient comes in with acute visual loss, if the visual loss is painful, you'll see probably eye redness. If there is an eye redness, think about keratitis, uveitis. If there is pain with eye movement, think about optic neuritis. If there is headache for the patient, please do not miss a giant cell arteritis, a temporal arteritis. So feel the temporal artery here if a patient does have headache. But also an acute angle closure will give severe headache. They'll give also abdominal pain. Probably these patients also do vomit. If a patient comes in with painless acute visual loss, think posterior. So think in the retina, because the vitreous and the retina, they do not have nerve endings. And so an acute painless visual loss, think about posterior segment, so the retina, the vitreous. If it's sudden, think about vascular, and we know this. If a patient comes in with sudden anything, sudden chest pain, sudden sudden loss in the sensation or motor activity, you know that it's a stroke, or a sudden MI, as in acute chest pain, sudden acute chest pain. You know that a vessel is blocked. And in ophthalmology, we do see a lot of vessels which are blocked, and we'll see now in the upcoming slides. So take from the previous slide, if painless acute visual loss, think posterior, and sudden means vascular occlusion, basically. And a medical history from the patient is very important. This is another thing that I want to bring to the discussion. We do see referrals from the hospital for patients. They refer these patients to us to tell us to look at the optic nerve to exclude papilledema. And it's either the doctor is not competent enough to do ophthalmoscopy to look at the optic nerve, or because the pupil is very small that they cannot look at the optic nerve. Honestly, if we have trabecomide in the healthcare, in the primary healthcare, you can just put a drop of trabecomide, and then the iris, the pupil will be dilated, and then just enjoy looking at the retina. Some doctors are afraid. They say, oh, if you dilate the pupil, then these patients might have angle closure glaucoma. Honestly, come to our OPD. Everybody gets trabecomide, even the patients with shallow anterior chambers, and they're more likely to get high IOBs. Honestly, the percentage, as I said, as you see from this study, it's only 3 in 1,000. So it's very small. It's 0.3%. So if a patient comes to you, if you do have trabecomide, just please feel free to use it. Just put a drop of trabecomide. And this is another point for discussion a bit later on. So in these patients, you might see if you put a drop of trabecomide and you look at the fundus, you might see blood as in vitreous hemorrhage. In these patients, you need to send them the next morning because the most common condition is proliferative diabetic retinopathy. As the beautiful thing about ophthalmology, you can see the pathology directly. This is a vein occlusion. I know the central vein is blocked, and so all the veins in the eye are leaking. This is a patient with central retinal artery occlusion. You see the whole cornea, the whole retina, sorry, is pale because there's no blood reaching it. There's another condition, a retinal detachment. So if you dilate the pupil, you might see that the retina is detached from superior. And that's why I say trabecomide is important even in the primary healthcare setting. Optic neuritis you might see, or ischemic optic neuropathy, you might see as in this picture, the optic nerve is not well demarcated and it's swollen, and there'll be hemorrhages around it. So in summary, dilate if you can. If you saw blood, you'll refer the next morning because this is most likely to be vitreous hemorrhage or a vein occlusion. If the patient, just pay attention to these patients. If a patient comes with acute visual loss within 1 hour and you cannot diagnose it, please send the patient immediately because it can be a central retinal artery occlusion. You've learned in your practice that if a patient comes in with an MI or a stroke, you need to send the patient straight away. Like for an MI, you need to send the patient within I think 4.5 hours or something like this to be managed with either angioplasty, a PCI, or need thrombolysis. Same thing with strokes that you need to send them within 3 hours. The same thing, but the retina goes ischemic within 1.5 hours, actually 90 minutes. And that's why I say if a patient presents within 1 hour, you need to send immediately. Otherwise, if a patient comes in with acute reduction in vision, but it has been for the last 3 or 4 days, you do not need to send the patient immediately. You need to send them maybe the next morning. Okay, there are other conditions which are important, and sorry to take only 5 more minutes, Dr. Zahir, and then we'll open the discussion.
And that's okay.
This is proptosis. Proptosis is very important, especially in children, because this is orbital cellulitis, and orbital cellulitis is very devastating condition because the optic nerve can go ischemic or it can go inflamed and be affected. These patients with orbital cellulitis or even tumors, this is a patient that I have seen, this is a bilateral tumor, it's a neuroblastoma. But these patients with proptosis, you need to send them on an urgent basis the next morning to be seen. Or otherwise, give a shot of antibiotics, IV antibiotics, and refer to the emergency department. You'll see patients coming in with children or mothers coming in, bringing their children either because they cannot see or they've seen maybe what we call leukocoria. Leukocoria as in this, leuko means white, chorea means pupil, and this patient has retinoblastoma. Please do not miss this condition. If a patient, I think children comes to you, newborn come to you for six week I think examination and then another examination. But if they come to you, please look at the red reflex and compare both sides. If you see a yellow reflex, please refer the patient straight away because this might be retinoblastoma. This is another condition with patients who come in with acute diplopia. This is an emergency. I'm asking this question, is this an emergency? Yes, this is an emergency. We need to see the patient straight away, not an, emergent. This is an urgent condition. This patient has the third nerve palsy in the right side. There is ptosis, the globe is abducted and depressed, and there is anisocoria, means the pupil in both sides are not equal because the pupil is affected in this side. And these patients will have diplopia and ptosis. These patients, we need to do CT angio for these patients because one of the most common condition is an enlarged posterior communicating artery, aneurysm, and the aneurysm has enlarged on a sudden basis that it affected the third nerve, and it can burst at any moment. So these patients, we need to see them on an urgent basis to exclude an enlarging aneurysm, and these aneurysms need coiling, otherwise they might burst and they get subarachnoid hemorrhage, or they might even die from these conditions. But the most common third nerve palsy is not actually an enlarging aneurysm in our setting. It's actually ischemic because of diabetes, uncontrolled diabetes. There's another condition. If a patient comes to you with, or especially in the emergency department, maybe a cricket ball or a blunt injury, and you see the patient has very ocular ecchymosis, and the eye is protruded out. It's proptosis. Think about sub or retrobulbar hemorrhage. These patients need immediately what we call canthotomy, cantholisis. So we cut, so infiltrate with lignocaine. The side you just cut, and you need to cut the lower crura of the lateral canthal ligament. This procedure should be known by all emergency physicians and all ophthalmologists. And to be honest, it's not very common, but you need at least to know that this might be retrobulbar hemorrhage and refer the patients. These are other common conditions that you see. Hordeolum means acute infection. And there are a lot of glands around the eye. Hordeolum acute infection, it can be external, like in this in a sty, or internal, like an inflamed chalazion. If a chalazion like this is being chronic, honestly, nothing will resolve this chalazion. This one on the left and the right hand side, the last picture. These needs incision and keratitis, and we just refer them to our clinic, and we do them as a clinic procedure. But these patients, you need to give them just fusidic acid and lubrication and hot compress, and they will resolve. Otherwise, if you see, as in the first picture, there's a lot of cellulitis around it, you're more than welcome to give them Augmentin, and these patients will resolve on Augmentin, just TID dose for 5 days. This is the last condition. Please, this is a patient that comes in 5 days post-cataract surgery, and you see that the patient has hypopyon. This is endophthalmitis. This is a true emergency condition. Every second counts for these patients. This is basically there is bacterial infection in the vitreous, and it will invade the retina, and the retina will go necrotic in a matter of hours to days. So if a patient comes in with post-op and has pain, please just refer immediately. I don't want you to deal with such cases. Okay, this is the last slide. In ophthalmology, there are only 4 conditions that I need to see immediately, and these are ocular injuries. If the injury is not only a corneal abrasion, please refer the patient straight away, especially chemical injury. If the injury is only small and it's a corneal abrasion, just treat it, as I said before, with prophylactic antibiotics and artificial tears, and see the patient in 2 days' time. The other condition is central retinal artery occlusion. As I told you, if they present with acutely within 1 hour, acute painless visual loss within 1 hour. The third condition is endophthalmitis. It's patients post-op who comes in with redness and drop in vision and pain. Please refer the patient straight away. Immediately means if the patient comes to you at 10 p.m., I need to see the patient straight away. Please do not let the patient wait until the next morning. And the fourth and last condition is acute angle closure glaucoma. But the other conditions, as I have, you can take a picture of this, and I hope Dr. Zahir will make this presentation available to everybody. The others, we can see them the next morning, like keratitis, ophthalmia neonatorum, orbital cellulitis, retinal detachment, There are semi-urgent cases like uveitis, scleritis. We need to see them within a week kind of picture. And then there are the routine cases. So take-home messages, vital signs of the eye, visual acuity, pupillary reaction, intraocular pressure. In ocular trauma, please do not forget life. In acute red eye, classify them whether they affect vision or not. If it doesn't affect vision, think about conjunctivitis. In acute visual loss, classify them if they are painful or painless, and painless, think posterior segment. There are two conditions that you need to take seriously along with the others that I have mentioned, but contact lens wearer keratitis and corneal transplant patients. And these are the four conditions that I told you to refer straight away: ocular injury, including chemical injury and orbital trauma, excluding basically abrasions, central retinal artery occlusion, endophthalmitis, and acute angle closure. Please, this is my email. I'm more than happy to hear your suggestion. And I'm also available on Twitter for those who want to ask any questions. And please just send me any questions that you like. I'm very enthusiastic about the future of the general practice and how we can work together in terms of giving the patient the best management that we can in terms of their ophthalmic condition. Thank you so much.
Thank you, Dr. Haitham, for the session. And I think we have some pending polls to vote for the clients.
Okay.
No, I think you can see now the first poll, and which you can read it out, Doctor.
Which of these is not a cause of ciliary congestion? So is not a cause of ciliary congestion.
No medical exam, they not.
Corneal ulcer. Be careful, not a cause of ciliary congestion.
You know, this is the trouble with the medical exams. They use these tricky things.
It's not. Sorry, I tried not to put the double negative. But, very important that acute angle closure, the first one, uveitis and corneal ulcers do give ciliary congestion. Conjunctivitis, simple conjunctivitis will not give ciliary congestion. Can we go to the next question?
I just will see the final result. Okay. Now, because people, they need to see the result, I launched it for them to see how this is. People now, they're seeing the result. So you can comment now, Doctor.
Okay, so I already commented actually. Conjunctivitis will not give the congestion unless the cornea is actually affected, which is rare.
Yeah. So let's go to the second question. Okay, now I'm launching it.
Okay, which of these is a feature of keratitis, corneal ulcer, rather than a corneal abrasion? So a corneal ulcer, which is exclusive or associated with an ulcer, but not an abrasion. يمكن اسئلتي شويه صعبه دكتور زهر.
ما عندك كل واحده بعيده تقول يعني.
لا لكن majority they're getting the correct answer.
Oh, great. Now we are reaching 65.
Okay, let's okay.
Now already have 91 participants here. Okay, let's end the vote. Now 70%.
Okay, so a keratitis will give you infiltration, and it will give you ciliary congestion, and it will give you epithelial defect. So if you put fluorescein, there'll be epithelial defect, and a trauma is associated. But a corneal abrasion will never give you a corneal infiltration. So you will not see an opacity. You will not see a whitish infiltration. But there'll be ciliary congestion, there'll be epithelial defect, and trauma might be associated. So the first answer is the correct answer. Can we go the last
Yeah, so let's go to this last one. Now it is launched.
So which of these is an emergency referral? دكتور زاهر أنا ما حطيت لهم رابع إجازة.
أشوف وين الرابع ما موجود يعني.
الرابع ما موجود.
إيه.
هذا السؤال يمكن يعني يمكن ما صحيح هذا السؤال. So be careful. If you don't want to vote, do not vote. I'm saying emergency referral means that I need to see the patient straight away. I don't want to see the patient straight away.
Because I'm trying to compare this vote with that slide. Okay, let's stop the vote. I think you can comment mainly, Dr. Haitham.
It's actually none of these. Uveitis, I can see them the next morning. Vitreous hemorrhage, I can see them the next morning. A retinal detachment, I can see them the next morning. I think the fourth condition, which is not actually put on the board, was endophthalmitis. Endophthalmitis, I need to see them straight away.
Yeah, thank you, Dr. Haitham. Let's start with the question. I mean, sometimes we get like a condition which are ophthalmology presentation, but usually it is like, I mean, cerebral accidents, like cerebral stroke, cerebral hemorrhage. I mean, where it could be like an emergency than an urgency issue. I mean, how people can differentiate in the primary health care? Because usually, I mean, cerebral stroke should attend immediately to the secondary care for the evaluation, I mean, CT scan or other acute intervention here.
Thank you, Dr. Zahir, for your questions. There's only one type of stroke that will affect only vision. That's cortical, basically posterior cortical stroke.
Yeah, posterior,
posterior. And these patients will present with homonymous hemianopia, either right or left side. And these patients will present with acute visual loss on both eyes. There are the conditions that affect the eye is rarely affecting both eyes. Normally, it will affect only one eye rather than both eyes. So if both eyes are affected and it's actually sudden, think about, of course, strokes. But the other types of strokes, they will, of course, have motor and sensory component to them.
Yeah, thank you. We'll go to the other question about you spoke about the chemical, I mean, injury to the eye, and it's discussed about the use of local anesthetist. I mean, what type is, because in primary healthcare, we do have it with epinephrine, and we use it for the suturing other issue. What type of anesthetist we should use in the primary healthcare?
I think maybe you do have local anesthetic lignocaine 1% or 2%. Maybe 2% would be like. What do you mean for what procedure do you want it, Dr. Zahir?
Now for the chemical injury, because it spoke about before irrigation.
So it's topical anesthetic. Topical anesthetic. It's called oxyprobaricane. We do have it. This is one thing that I've put here. A local anesthetic. It's topical basically. It's not.
Yeah, it's the not, topical one. Yeah.
Do you have it in the primary health care?
I'm not sure it is available. What you have discussed. So I think we need to discuss it with the drug committee.
Who are in the administration, it's very important to have basically local anesthetic, topical local anesthetic. We have oxyprobaricane, tetracaine. There are various formulations, but one will suffice. And then in these chemical injuries, if you try to put directly water in your eye, it's actually very uncomfortable feeling. But if you put a topical local anesthetic, then the patient will tolerate the irrigation for even 30 minutes.
Yes, Dr. Haitham?
معك دكتور زاهر.
Okay, great.
Questions here in the...
Okay, you can go to the question, and some questions are on the chat also.
The chat is Amira Salim is asking which topical anesthetic can be used. So I already answered this. Harith Al-Bahri is topical tetracycline contraindicated in neonates and infants. What about chloramphenicol? There's only, I think, one study that have looked at chloramphenicol, not drops, but actually systemic chloramphenicol, and it has been associated with aplastic anemia, and that's why there has been a lot of fear from the scientific literature on using chloramphenicol for less than 1 year. But honestly, it's safe. But I urge you, maybe it's best not to use it. And for these patients, use fusidic acid. If it's only simple conjunctivitis, and you can give them Vigamox. So moxifloxacin, Vigamox from outside, to buy from outside, and they can use it 4 times a day. So moxifloxacin, I'll write it on the moxifloxacin. So it's the most safe drug, topical antibiotic that we have at the moment for neonates. But for children more than 1 year old, go ahead. You can use chloramphenicol. Tetracycline, it's fine actually, unless you use it for a very long time. It's been associated with bone and teeth problems.
Yeah.
Then Harith Al-Bahari, we have 3 topical antibiotics: tetracycline, gentamicin, and chloramphenicol. Which is the preferred one for children in suspected bacterial conjunctivitis? So as I said, if they are more than 1 year old, chloramphenicol, if they or fusidic acid. But normally fusidic acid is not that strong, honestly. So, but if they are less than 1 year old, use moxifloxacin, Vigamox. It's called Vigamox. This is its trade name. It's a 4th generation quinolone, and it's very safe in children.
Okay, let's go to the question sessions there, Q&As. Haitham.
Okay.
Okay. How to differentiate؟ تضغط على Q&As دكتور، يمكن تبقى فوق أو تحت. I'll speak the question. I'll read the question for you. I mean, from Dr. Ghulam, I mean, he said how to differentiate posterior vitreous detachment and vitreous hemorrhage clinically, as the history will be almost similar with the flashes and floaters.
He's right, but if you dilate the pupil, you'll see blood, basically.
Okay, great.
You'll see blood. If you cannot dilate, let the patient come to us the next morning. But it's a very common condition, posterior vitreous detachment, because as people age, the vitreous becomes liquefied and it detaches from the posterior retina, and they will have floaters. So this is a common condition that you will see. يقول لك الذبابة الطائرة, يعني كده they'll see a fly going in front of their vision.
Is it the same to differentiate between posterior vitreous detachment and the retinal detachment? Dilatation will give you the same.
Yeah. With similar presentation. They'll come in with floaters, they'll come in with flashes, يعني مثل البرق basically, so strong flashes, and they will have, if it's a retinal detachment, they might have visual field defect, يعني مثلا كأنها ستارة من فوق نازلة ولا طالعة من تحت ولا من الأطراف. Otherwise, we need to see the patient the next morning to exclude a retinal detachment.
Yeah, Amira is asking about if someone present. I mean, she wanted to rectify this one. If someone presents with the chemical burn, but on examination there is only small abrasion, shall he be referred as an emergency?
Well, it's a difficult question. If it's only if the chemical injury is not that strong, مثلا أحيانا only عطر ولا شيء بسيط يعني, you're more than welcome. Just treat it as a corneal abrasion. If you think the chemical injury is severe, like in a household مثلا cleaning equipment, or in a site, in an industrial site, I'd rather see these patients because the damage might be internally, and these patients can have high IOB in the same setting, as well as ischemia to the limbal cells. So I'd rather see them actually, unless the chemical injury is small.
Yeah. Sometimes the children do accidentally, I mean, spray perfumes on their eyes. So this would...
It's okay. Just irrigate and then give them local, يعني topical antibacterial, يعني antibiotic, just prophylaxis, as well as artificial tears.
Yeah, just Muhammad Sayyid is just re-asking the question about use of antihistamines in allergic conjunctivitis in children from 4 to 11 years.
أيوة. it's يعني سؤاله إيش إنه whether we can use it or not.
Yeah.
It can be used, of course, but I want you from this talk, honestly, because we see a lot of patients who go to primary practice, and when they have a red eye, they'll be given everything basically to cover everything. They'll be given antibiotic, they'll be given antihistamine, and they'll be given artificial tears. This is not good practice, honestly, unless you know the diagnosis. Why do you give everything to the patient? So this is not a good approach to give everything, because the eye drops themselves have preservatives, and the preservatives can irritate the eye more if you do not treat the condition itself.
Great. Dr. Mariam is asking, I mean, this is more of a suggestion to have like a national guideline and for the primary health care on the common eye conditions. Of course, there is like one flow chart. We have it for the acute eye condition, but it may not be well circulated, but it can be like updated. I think this is a message to the primary health care. I mean,
I have actually been involved in writing guidelines to the primary health care, and we do have a document in the Ministry of Health for primary health care guidelines of when to refer, what to refer, and what medications to give. So it's available in the Ministry of Health. If some of you actually can get it to your colleagues, that would be great. Dr. Zahir? I cannot hear Dr. Zahir. The Q&A is not opening with me, unfortunately.
Okay. Can you hear me now, Doctor?
I can hear you now.
Okay. About unilateral red eyes with history of trauma, should they refer them immediately?
It depends, as I said, on the mechanism of trauma. If the mechanism of trauma is only little, you can just give them a prophylactic antibiotic, because the abrasion might be small and you cannot pick it up. But otherwise, you can refer the patient.
Yeah. Sometimes you get like some newborns, I mean, with the, lacrimal gland duct obstruction. Sometimes they get mixed up with the infantile, neonatorium, condition. How we can differentiate with this issue?
So ophthalmia neonatorium, they'll present very early, if within the first week. Within the first week, and there'll be pus. There'll be really pus in the eye, rather than only a mucousy discharge, as in nasolacrimal duct obstruction. This is a very important topic, nasolacrimal duct. Please, so you need to tell the mothers to do massaging, and the massage is, so you put, I'm removing, I don't know if you can hear, but you have to massage, so you have to put the finger over there and you have to massage going down. It's not massaging the bone, it's actually massaging the inside of the medial side of the eye. And you can let the patients actually, or the mother, just press and release, press and release, press and release. That's the way to do it. But if a patient within 6 months did not resolve, I prefer the patient to be referred, because we need to open the nasolacrimal duct in the first year, like when they are 1 year old. If you keep them for more than 1 year old, then the opening might not be sufficient, and they might need further surgery.
Yeah. Mujahid is asking about the relationship between the space occupying lesion and the sixth nerve palsy. Is it commonly encountered?
Sixth nerve palsy is very commonly encountered, and the most common condition is actually ischemia to the abducens nerve or sixth nerve, and it's because of uncontrolled diabetes or hypertension. But false localizing sign as in space occupying lesion, we do see it, but it's less common. And these patients with space occupying lesions, if you dilate their pupil, you might see that they might have papilledema. But acute sixth nerve palsy, we need to see them the next morning, actually.
Yeah. The question about mydriasis in the eye, is it very common here in Oman? Do you see it much?
Ophthalmomydriasis.
Yeah.
والله ما أعرف. How do you guys know about this condition? And I'm really
Dr. Dalal is asking.
But we do see it. Ophthalmomydriasis means that there are basically the flies. The flies, they put their eggs in trees, and these flies or these eggs can fall on the eye, especially in children that يروحوا مزارع وكذا. It falls in the eye, and then these eggs they open up, and there'll be a lot of larvae inside the eye. We do see it. It's not very common. We do see probably about 10 cases per year in Al-Nahdha hospital.
I've seen it once in the ear also. But only once with experience with it.
It's actually difficult to treat these patients because you need to remove the larvae mechanically. Otherwise, they'll have a lot of discomfort.
Yeah. Cases, client with GSSBD deficiency, do you need to be worried from like gentamicin, other drugs, or any special precaution to be?
Only ciprofloxacin. But if you're going to give it systemically, but from a drops point of view, no.
Okay, fine. Of course, the question about use of antihistamines, you mean the topical, antihistamines? Yeah. And another question. Okay, she said she have seen that the larvae in North Sharqiya. The larvae, yeah. So, do they need to refer immediately at the question about the larvae, or they need to try to take it off themselves?
Basically, the next morning. You can give a lot of, just irrigate the eye, because these larvae might, you can remove them with irrigation. Irrigate the eye, and then give them antihistamine and artificial tears, and also because these larvae walk on the cornea, you can give them chloramphenicol and refer the next morning to the ophthalmologist, and then we can mechanically remove the larvae if they are still in the eye.
Yeah, the question about it's a common question usually in people, they ask when they drive at night, they see like blurred vision during at night. What is the usual cause for this?
Cataract in old age, cataract.
Yeah, what about the younger age?
Younger age, think about keratoconus. Keratoconus is a condition, القرنية المخروطية. It's about 10% of people in Oman, 10% of young people in Oman have keratoconus, and this is هذا هدفي في الحياة في الوقت الحالي, is to change the lives of keratoconus in Oman.
Okay, so you need to have a big program on this issue.
Inshallah.
Inshallah. What about the subconjunctival hemorrhage? Is it like more of like emphasis on the question itself? Is it an urgent? Or
we don't need to see subconjunctival hemorrhage, especially the spontaneous subconjunctival hemorrhage. You just need to treat it with artificial tears, even if the patient feels uncomfortable feeling. And you do not need to stop the blood thinners. If the patient is on aspirin or clopidogrel or warfarin, you do not need to stop, because the bleed stops itself, honestly. But if the patient comes in with trauma and you see subconjunctival hemorrhage, maybe we need to see the patient, because we need to exclude an open globe injury, especially if it's scleral involved.
Great. Okay, I think we reached 1 hour and 15 minutes.
I'll answer the last question, Dr. Mohammed Bareri. How to treat keratomycosis? This is basically fungal keratitis. Fungal keratitis, all keratitis, you need to refer the patients, and we treat them. We treat them with every 1 hour drops of fortified, means very high concentration of antimicrobials, either antibiotics or antifungals or even anti-parasitic like in acanthamoeba keratitis.
And it is an emergency referral to the, secondary care.
It's an urgent referral. It's not an emergency. We can see them the next morning.
Great. So shall we wrap it up?
I think so. I hope Dr. Zahar, best for you guys, maybe if we have a shield in the primary health care, please write it down. Shield is very important, especially for post-trauma cases, especially of open globe injuries. If we can get tropicamide to the healthcare, to the primary healthcare, as well as local anesthetic, I think you do have fluorescein strips, but the topical anesthetic is very important. So these are things that maybe will be really beneficial and will be great to be available in the primary healthcare.
Yes, and then the future is coming for the artificial intelligence and the retinal retinoscopy should be there soon.
Yes, hopefully we're hoping by artificial intelligence also that for diabetic retinopathy we don't need to see patients every year to examine the retina. Maybe we can only take a picture and then the computer will tell us if this picture is suggestive of treatment or not.
Great. Okay, thank you, Dr. Haitham, for the nice talk, and for the audiences for the keeping with us, inshallah. And it will be recorded on the YouTube, and after a review, and you'll get your certificate. Can you hear me?
I can hear you. Your voice went away.
Oh, great. Do you have any final message here for the colleagues?
Final message, I'm very happy to see this number of audience in this. I'm always happy to talk about ophthalmic conditions and to work together in terms of improving the eye diseases, management of eye diseases. Final message is just remember those 4 conditions that you need to send in the middle of the night. Otherwise, we're more than happy to see them the next morning.
And also, you are open for discussion by call also.
Please, on email or on Twitter, please feel free to send me any questions. Thank you.
Yeah, and the message for the primary healthcare: don't hesitate to discuss the case with the secondary care. Because they are also there, and you are there to help the patient.
This is very important. I actually received some calls from GPs or FAMCO. I'm very صراحة happy to discuss cases. If you want to discuss a case that you don't know whether to refer or not, just call the emergency department. Tell them to give you the on-call ophthalmology on-call duct phone or their GSM, and you can call them and discuss a case. Because sometimes you refer the patients and then the patient actually does not get accepted in the emergency or by the ophthalmologist. تعبي له حال المريض انه يروح emergency department and do not get accepted.
And you get clarified for your questions or sometimes differential. Also you enforce your decision making also.
It's good to have the discussion. It's very healthy discussion.
Okay, great. Thank you, Dr. Haitham. Thanks all, and wish you a nice night, and see you on the second session, inshallah, next week. Okay, assalamu alaikum. مع السلامة. إلى اللقاء.